Thank you, Kumar, for that warm introduction. And I'd like to thank the organizers of this meeting for inviting me to give this talk on uncommon mutations in non-small cell lung cancer. As you heard in the previous panel discussion, it's not, even though they're uncommon, they're seen fairly commonly. And I'd like to talk about certain mutations that have had data presented over the past few years. So I don't need to tell you about this particular slide. You can see lung cancer today, especially lung adenocarcinoma, is not one disease, but multiple different diseases with completely different treatment options. What I will do over the next 20 minutes or so is go over some, I won't talk about EGFR or KRAS, which are, or ALK, which are fairly common, but focus on the less common mutations for which we have treatments available, the RET, ROS, MET, HER2, and talk about some of the clinical trials that have been presented over the past year or two, including some work that we have done ourselves. As you can see, this is not limited to adenocarcinomas, as was discussed in the panel discussion earlier. You see some of these mutations in squamous cell lung cancer as well. So looking at the uncommon EGFR mutations, the major uncommon mutations are G719X, L861Q, and S768I. We've had a little bit of talk earlier in the panel discussion about some of these mutations. And then you have the other uncommon mutations like exon 18, which includes E709X or exon 18 deletion, other exon 19 L747, either insertions or deletions. Then you have the exon 20. These are not the exon 20 insertions. I initially had some slides on that, but I found that there is a talk right after this, so I will not talk about those. But you have other exon 20 mutations, L774X, R776X, and others. And then the L8, exon 21 deletion, L858M, which is different from the L858R. As you can see here, these are the various locations within the EGFR gene where you see some of these mutations. And the interesting thing about these mutations, as was mentioned earlier, is that these patients do not respond to your standard EGFR TKIs like osimertinib, alartinib, gefitinib. There is data on afatinib, which is currently the only approved drug for these mutations, but I'll present some data on osimertinib, which were published earlier this year. So these are where you see the various uncommon EGFR mutations. Of the uncommon mutations, exon 18 is about 5%. The bulk of the mutations seem to be present in exon 19 and exon 21, similar to what you see with the activating mutations, and then a few exon 20 mutations as well. So this was a multi-center retrospective study that was published earlier this year from Israel, but this included data from 22 centers in 9 countries and a total of 60 patients. And if you look at them, all of these patients were treated with single agent osimertinib, and as a group, they had a progression-free survival of around 9.5 months, overall survival of slightly over 2 years, and osimertinib seemed to have a good response rate of around 61%. And then they subdivided these patients into patients who had only the uncommon mutations, or those who had uncommon or complex mutations like we were discussing earlier. And interestingly, both the uncommon only group and the complex mutation group both had a response of around 60%. Of course, the big difference here was that the patients who had combination mutations had a higher progression-free survival and overall survival compared to those who had just the uncommon mutations. And then when you look at the specific uncommon mutations, the G719X, which we were talking about earlier, osimertinib seems to have a response rate of around 47%. And when you looked at those patients who had just the G719X, they seem to have a response rate of around 53%. Median progression-free survival of around 8 months, and median overall survival in the complex, just the single mutation group was about 1.5 years. When you look at the other most common uncommon mutation, the L861Q, you had a response rate of around 80% with a progression-free survival of 16 months and an overall survival of 26 months. And based on these data, I would argue that osimertinib is probably the best agent for these uncommon mutations over afatinib. We all know how difficult it is to treat patients with afatinib because of the side effects. Comparatively, osimertinib is much easier to treat, and this has been my go-to agent for patients with these uncommon mutations. Moving on to ROS1 fusion, ROS1 is seen in about 1% of non-small cell lung cancer. Usually these patients have a light or a never smoking history, almost always adenocarcinoma. And if you look at the most common fusion partners for ROS1, these are CD74, EZR, SDC4, SLC3M2A. But the most common one is the CD74 ROS1 fusion. Crizotinib was the first drug that was studied in ROS1 rearranged lung cancer. This is a paper published by Alice Shaw about 9 years ago now. In a total of 50 patients, they saw a 72% response rate with crizotinib with a median duration of response of around 1.5 years. Since then, there have been multiple other drugs that have been studied. This is a data of entrectinib, pooled data from 3 different trials. And as you can see here, entrectinib seems to have, almost all patients seem to respond to entrectinib, and the median progression-free survival and the overall survival seem to be quite high with entrectinib. Ceritinib was the other drug that was studied, and again, as you can see in this waterfall plot here, almost all patients respond to ceritinib, and the duration of response seems to be quite high with patients with almost a year, 1.5 years on ceritinib. And most recently, the Trident-1 data were presented at World Lung earlier this year, showing that the duration of response was significant, with a median duration of response of almost 3 years in these patients with repotrectinib in ROS1 rearranged lung cancer, based on the results of the Trident-1 study. This here table shows the different agents that have been studied in ROS1 mutated patients. As you can see here, we talked about crizotinib, ceritinib, brigatinib, 1 patient, taletrectinib, almost a 50% response rate, entrectinib and repotrectinib, almost 80% response rate, and lorlatinib. I did not talk about this drug, but this was a single cohort in an expansion phase 2 study with a response rate of around 60% and progression-free survival of around 21 months. But no, we're not supposed to compare trials against each other since these drugs are not compared head-to-head, but numerically it appears that repotrectinib has probably the highest progression-free survival of all these agents. And this drug was recently approved by the US FDA for ROS1 fusion patients. As we know, these are all tyrosine kinase inhibitors, and not surprisingly, resistance develops to them. Unfortunately, we don't have too much information about the resistance mechanisms against ROS1, but we are finding out that secondary mutations seem to be the most common identified cause, as you can see here in the post-crizotinib and the post-lorlatinib groups. Not surprisingly, the post-lorlatinib groups have some complex mutations that are seen over here. So, as we get more information, we may be able to identify multiple other agents that may be active against these resistance mutations. Moving on to BRAF V600E, this is a cartoon showing the functioning of the RAS-RAF pathway. Normally it requires a growth factor, and once this growth factor binds to the receptor tyrosine kinase, it helps normal cell proliferation and survival. When you have a mutation like the V600E that leads to a constitutional activation of BRAF, leading to cell proliferation and survival, even in the absence of these growth factors. What we're trying to do here is block this constitutional activation by using BRAF inhibitors and combining them with MEK inhibitors to decrease some of the side effects associated with BRAF inhibitors alone, and the net result being decreased cell proliferation and survival. There have been multiple studies of either BRAF agents as a single drug or in combination with MEK. This was a study that was published almost 8 years ago now, looking at vemurafenib in BRAF mutated cancers. Multiple different cancers were studied, including lung cancer, colon, and thyroid cancer. And as the top panel here shows the data with the lung cancer, showing that the vast majority of patients had a shrinkage in their tumors. The response rates were around 45% or so. When you look at a combination of dabrafenib and trametinib, you can see here median progression-free survival of almost 15 months and a median overall survival close to around 20 to 22 months in this single-arm study of using dabrafenib plus trametinib. And if you look at the swimmer's plot here, you can see that there is a group of patients who have long responses and are tolerating the drug for a prolonged period of time. BRAF TKI resistance has been noted like every other tyrosine kinase inhibitor, and the most common resistance mechanisms seem to be the development of this PTEN mutation, KRAS Q61R, and NRAS Q61R. And if you have used a combination of BRAF and MEK, you tend to see this MEK mutation as well, which also is a resistance mutation against BRAF TKI, especially when used in combination with a MEK inhibitor. HER2 mutations are seen in only about 2% of lung cancers, and one of the important things to remember about HER2 in lung cancer as opposed to breast cancer is in breast cancer the most common HER2 abnormality seems to be HER2 overexpression, whereas in lung it's an equal combination of HER2 mutations and HER2 expressions. And this was a large database study which looked at 321 mutations out of a series of over 12,000 individuals that were analyzed for HER2. Of these 321, about 1.5% of patients had a mutation, that's 197 patients, and the remaining patients had a gene amplification. So if you look at all lung cancers, HER2 mutation is seen in about 1.5%. Gene amplification is seen in about 1%. So about 3% of patients have some HER2 abnormality. And unlike in breast cancer where gene amplification or HER2 overexpression seems to be most common, here it seems to be half and half. And the gene amplification seem to function differently as compared to overexpression in lung cancer. So this was the Destiny Lung 1 trial looking at trastuzumab deruxtecan for HER2 altered non-small cell lung cancer, and these included patients with both mutations and amplification. They had to be unresectable, they had to be refractory to standard treatment, good performance status, measurable disease. The first cohort was HER2 overexpression, which IHC3+ or IHC2+, and then the second cohort was HER2 mutated. And both these groups got trastuzumab deruxtecan 6.4 milligrams per kilogram every 3 weeks. Primary endpoint was overall survival, with secondary endpoints of PFS, OS, duration of response. The median duration of treatment was 18 weeks. And if you see here, this was the group of patients that had the mutation, and the median progression-free survival was 8 months. The median overall survival was around 17 months. You can see the waterfall plot here, those patients with mutations, the majority of them had a decrease in the size of their tumor. If you look at the patients who had HER2 overexpression, unfortunately they did not do as well. Median progression-free survival was only about 5 months, with a median overall survival of around 11 months. The response rates were much lower. For IHC3+, response rate was 20%, stable disease was about 60%, giving a disease control rate of 80%. For IHC2+, one patient had a CR, about 23% had a partial response, and the remaining had stable disease. Median duration of response was less than 6 months. This would suggest that patients with HER2